This podcast is for educational purposes only and is intended for medical professionals. It does not provide medical advice or establish a provider-patient relationship. Always consult a qualified healthcare provider for medical concerns. While we strive for accuracy, medicine evolves, and listeners should verify information with trusted sources. Views expressed are personal opinions and do not reflect any organization's policies. Listener discretion is advised, and we assume no liability for reliance on this content. All rights reserved. Unauthorized use is prohibited. Welcome to Pathora, Medicine in 5 Minutes, where we simplify complex medical topics quickly, clearly, and maybe even a little fun. Today, we're talking about hypertension in kidney disease, a condition that's both a cause and a consequence of kidney problems. Whether you're a medical professional, a resident, or just medically curious, stick around as we cover why it happens, how to diagnose it, and how to manage it effectively, all in under 6 minutes. Why does hypertension occur in kidney disease? Hypertension and kidney disease are a vicious cycle. High blood pressure can damage the kidneys, and damaged kidneys can raise blood pressure, leading to progressive renal failure. Key mechanisms behind hypertension in kidney disease. 1. Sodium and fluid retention. Failing kidneys can't excrete sodium properly, causing fluid overload and high blood pressure. 2. Renin-angiotensin-aldosterone system, RAS activation. Overactivation of the RAS leads to vasoconstriction and sodium retention, further raising blood pressure. 3. Sympathetic nervous system activation. Increased sympathetic activity contributes to vascular resistance and hypertension. 4. Reduced nitric oxide and endothelial dysfunction. Loss of vasodilation ability promotes vascular stiffness. Who's at risk? Patients with chronic kidney disease (CKD), especially stages 3 to 5, glomerulonephritis causing inflammation and scarring. Diabetes mellitus, a leading cause of diabetic nephropathy. Polycystic kidney disease, where cyst growth compresses kidney tissue. Renovascular disease, like renal artery stenosis. Diagnosis: know the numbers. Hypertension in kidney disease is diagnosed using blood pressure readings greater than or equal to 130/00 for 80 millimeters of mercury, the target for CKD patients. Urinalysis: check for proteinuria or hematuria. Serum creatinine and estimated glomerular filtration rate (eGFR) monitor kidney function. Albumin to creatinine ratio detects protein leakage, an early marker of kidney damage. Renal ultrasound evaluates structural abnormalities like cysts or atrophy. Renal artery Doppler identifies renal artery stenosis if secondary hypertension is suspected. Treatment: control blood pressure, protect kidneys. Blood pressure targets for CKD patients. Aim for less than 130/80 millimeters of mercury. For patients with proteinuria greater than 1 gram per day, strive for even tighter control to slow progression of kidney damage. Medications, first line and beyond. 1. RAS inhibitors, gold standard. ACE inhibitors, like lisinopril or enalapril, and ARBs, like losartan or valsartan, are first-line agents. Benefits: lower blood pressure, reduce proteinuria, protect against glomerular injury, monitor for hyperkalemia, potassium greater than 5 milliequivalents per liter, serum creatinine rise, acceptable up to 30% increase from baseline. 2. Diuretics, volume control. Thiazide diuretics, effective in early CKD when eGFR is greater than 30 milliliters per minute. Loop diuretics, like furosemide, preferred in advanced CKD or fluid overload. 3. Calcium channel blockers, CCBs, dihydropyridines, like amlodipine, for vasodilation and blood pressure lowering. Non-dihydropyridines, like diltiazem, if proteinuria persists despite RAS blockade. 4. Beta blockers and alpha blockers. Use in patients with HE-RT failure, post-myocardial infarction, or resistant hypertension. 5. Mineralocorticoid receptor antagonists, MRAs, spironolactone or eplerenone, helpful in resistant hypertension, but monitor potassium levels. Lifestyle modifications, small changes, big impact. Sodium restriction, limit to less than 2 grams per day. Dietary approaches to stop hypertension. DASH diet, focus on fruits, vegetables, and low-fat dairy. Weight loss, aim for a body mass index BMI less than 25. Exercise, moderate activity for 30 minutes, 5 days a week. Limit alcohol, no more than 1 drink per day for women and 2 drinks per day for men. Smoking cessation reduces vascular damage and improves blood pressure control. Monitoring and follow-up. Blood pressure checks at home and clinic visits. Lab tests. Monitor potassium, creatinine, and eGFR every 4 to 6 weeks after starting or adjusting medications. Urine protein levels to track disease progression and treatment efficacy. Key takeaways. Hypertension in kidney disease is both a cause and a complication, requiring tight control to slow progression and protect renal function. First-line treatment includes ACE inhibitors or ARBs, often combined with diuretics for volume control. Lifestyle changes like low-sodium diets and exercise enhance outcomes. Close monitoring of blood pressure, renal function, and electrolytes ensures safe and effective management. Key takeaways. Dialysis replaces kidney function in cases of acute kidney injury, or end-stage renal disease. Indications follow the U criteria: acidosis, electrolyte imbalance, intoxications, fluid overload, and uremia. Hemodialysis is more common, while peritoneal dialysis offers home-based flexibility. Monitoring includes labs, nutrition adjustments, and access care to prevent complications. That's it for today's episode of Pathora, Medicine in 5 Minutes. Don't forget to subscribe and leave us a review. Thanks for tuning in, and as always, stay curious and keep learning.